And I thought we'd start just by going through with introductions and give us any updates or things of interest, like Jim, what's going on with the Behavioral Health Council, if anything. Is it okay? Why don't we start with Jim?
Well, I guess I don't have to introduce myself, but I'm Jim Novelli, Executive Director at Discovery Behavioral Healthcare, and actually a board member of the Washington Council for Behavioral Health. And so what's going on? Actually, we're all excited because everything we asked for and lobbied for mental health, we got from the governor. Got a rate increase for Medicaid, a 7% rate increase, which will go into effect on January, and $100 million bridge money that should start being dispersed somewhere at the end of hopefully July 1st somewhere to help agencies until that 7% kicks in, because it really equates out to about 7% once you distribute it. Basically, to help us with recruitment and retention, try to get the workforce back up in place. So yeah, lots of good news coming out of there in the sense of a lot of money being invested back in the behavioral health system, which is something that most state legislatures tend to cut from usually. So it's nice to go in the other direction for once. And in the meantime, just been working on several grant proposals and more to come. That's all. So
more to come. All right. Well, thank you for being here. How about Patrick Johnson?
Hello, everyone. It's always good to see all of you. NAMI is rolling along. NAMI Jefferson County. I mentioned just before the meeting that NAMI Walks is the big fundraising event for NAMI Washington. So we're busy supporting that, and maybe I'll get in touch with all of you for a donation. So anyway, glad to be here.
Thank you. Good to have you here. How about Joe?
Hello, everyone. Sheriff Knoll, Joe. Good to see everybody. Like Patrick said, a couple of things just from the sheriff's office. Our body cameras are up and running. That seems to be working well so far. Our navigator program with Stephen Eccles just keeps getting better every day. I probably shouldn't talk about it. I'll jinx ourselves. Another thing that I am kind of excited about, and James and Gabby are on the CJTA committee with me, which it's money that's available for like drug court, therapeutic courts. And I feel like we're really moving forward in how to spend that money in a good way. So we had I thought a really good meeting the other day. And so anyway, that's my update.
Sounds like there's a lot going on there. Exciting about those CJTA funds.
Yeah.
Gabby.
Hi, sorry. What's going on with us is we're working on getting our mobile unit licensed, hoping to have that done within the next couple weeks. The remodel on that should be done hopefully soon as well. And we'll be able to get going out to South County and Forks, other areas that don't have services or have limited services. We've partnered with OPHS to do that, so that's exciting. And
is that that's the grant that you guys submitted with OLICAP? Do I have that right?
I did submit a grant with OLICAP that would fund that. Whether or not we get that grant, we're still moving forward with doing that. That grant would just supplement, basically it would pay for the staff on the mobile unit and pay for gas. And so the mobile unit, we're looking to have that going by the summertime. So I think that grant would start in September, the end of September. So that's exciting, and yeah, still working pretty close with the Port Townsend Police Navigator to get people into services, and that's pretty much it.
Well, good luck getting across the bridge there.
We got across.
Oh, you're across. All right. Good.
Yeah. Now I made it home, so I need to go get a phone charger, so I'm not using my secretary's phone anymore.
All right. Good to know.
Yeah.
Kelly.
Hi, good afternoon. Kelly Parcher, Executive Director of OWL 360, otherwise known partly as the Pfeiffer House. Things are going good with our new nonprofit. We were just able to this week put a posting in the paper, thanks to the HRSA funding, to hire a part-time program developer as we move forward in our organization to really look at developing that community resource center. So I've kind of been putting our eyes on some available spaces that would be a good match for, joining with our community partners and being able to have a good space where our young folks can kind of come and get services and maybe have kind of a safe space to meet for other matters. So that's where we are today. And then looking forward to, also our county just got identified as an anchor community. So we'll be having some up and coming meetings with that, which is all around collaboration and community partnership. Really directed specifically to that young population of 12 to 24-year-olds, which is right where our target is.
Oh, that's exciting. And I'm glad we got that contract through and you just were right out there getting some people hired on it.
Yeah, no, I appreciate your guys' support, definitely.
Jim. Nope, sorry, we already did Jim. How about James Kennedy?
Hi, good afternoon. James Kennedy, County Prosecuting Attorney. And I guess this is last month, but I don't know if I mentioned this last time. We, for the first time in 10 years, finished our child abuse protocols, which are supposed to be done every 2 years. And so that was a pretty important milestone. I had meant to get that done right out the gate within 2 years of taking office, but COVID kind of sidelined a lot of that. And I know there's quite a few people on this call who helped make that possible. So again, thank you to all of you. I really appreciate it.
That's exciting. That's a big thing to check the box on. Apple.
Good afternoon, everyone. I'm Ethel Martin. I'm the director at Jefferson County Public Health. What is new with us? Well, we are having some, slight shifts in terms of COVID response. So, that's what we think about all the time over here. There was a slight lull or a plateau. We've gone up a bit lately. You probably are all aware that our risk indicator has gone up from moderate to high just recently. And we're navigating that pretty clearly. We have a lot of folks in the county who are using the self-test kits that we distribute all around. Thank you to law enforcement, fire and rescue also, who had some of our test kits out at their places around the county, and others as well. We have a lot of folks who are calling in with their positive results and letting us know so that we can offer them wraparound care and guidance, and also helping us keep our numbers and data clear and updated with self-report. So that's an interesting feature about Jefferson County. We are really leading the way in terms of having response to that mechanism of voluntarily having folks in the community let us know, so that we can keep our eye on trends, and then we're working on smaller outbreaks here and there. So other than that, we're doing a lot of internal work here with staff, succession planning. We're also got a few new grants coming in, especially recently with regard to diversity, equity, and inclusion, with regard to COVID work, and some other new grant funding for our sort of emergency disaster preparedness in terms of looking ahead at what our communication strategies will be. So that sort of feels like after action kind of work with regard to the pandemic just happening, but I think it's actually the future of what we need to do more and better with regard to any kind of disaster or emergency. There's a lot more, but I think I'm going to let Denise, when she goes, maybe speak specifically about programming in her division. Thanks, everybody.
Thank you, Apple. It's good to have you here and hear the update. Chief Olson.
I do not have any grants coming in, unfortunately. I wish I did, but I don't. Continue to work on staffing, recruiting, and retention. We have 6 currently in the pipeline between new employees and laterals. So we're making progress, but it is slow. That's about all I have.
Okay, thanks for being here. Denise. And Denise, I wondered if when you are talking to us, if you could tell us a bit about the thing that happened in the newspaper with the cartoon.
Okay, hi. I wasn't prepared to say anything to anyone,
I'm
but
sorry.
no, that's all right. So the Community Health Division is submitting some a grant proposal for some funding to bolster mental health services in the school-based health clinics, which will, really be helpful in light of our healthy youth survey statistics and also the common talk among school level professionals about the state of the schools and the students. And so that's something that we're doing that it will impact the community. We recently reached out to the Jefferson County leader in response to a cartoon that had been published in the April 6th leader. Nat Nichols, had attacked us pretty thoroughly with false information and that hadn't been verified. And so I worked with the leader and with Nat very successfully to remedy that situation. And Nat has posted a new cartoon that corrects herself. And then the leader provided space for us to provide out the true details of our naloxone distribution program here at the health department. So that worked out really well, and it maintained our relationship with the leader and maintained our relationship with a community member who has a venue to make a lot of noise. And so we felt really good about that and felt that they were very professional. We appreciated their professional integrity, and we presented our best face also. So that felt really successful. And like, gee, Apple, I don't know, what else do we have going on over here? Lots of internal stuff that I'm not going to share at this meeting. And then lots of, projects that are ongoing. Yeah, but that mental health funding that we're going after is the big one that's most important to this group. Yeah.
Great, thank you. And thank you for the time and energy you spent on, making a productive reaction and outcome from that misinformation that went out in the leader. Sheriff Knoll, I saw your hand.
Yeah, I wanted to say the same thing. I thanks for taking that on, and you did yourself proud the way that you addressed it. So anyway, I'm just going to leave it at that. Had some experience with that person. So that's all I'm going to say.
Thank you, Sheriff Knoll. And thanks for the thumbs up, Greg.
Everybody needs a Denise on their team. Commissioner Brotherton.
Yes, yeah, kudos, Denise. That was yes, adeptly played. I'm Greg Brotherton, County Commissioner. I guess I'll share something that maybe I have a lot of interface with a lot of folks here, but I'm excited through the Olympic Area Agency on Aging. We are in an RFP, have an RFP open right now to set up a home share program for seniors that are looking to supplement their income while also creating workforce housing. So it'll be kind of a program, an intermediary that vets pairings between workforce and seniors, presumably, primarily, who want to open up their homes to address our housing crisis. So really excited about that process on the horizon.
It is exciting. Thank you. Brian Gleason.
Hi there, Brian Gleason, Jefferson County District Court, here for Behavioral Health Court. We have had recent graduations, and we're having another graduate at the end of the month, and then we'll have another one towards the middle of May. So a lot of our long-term people are graduating our program successfully. So yeah, we've had a bunch of people in there that have navigated the system for many multiple years. One of them's been in there for almost 3 years and finally is making it out. So we're getting there slowly. So it's a good thing to see him leave the nest, so to speak.
That's great news. Judd.
Hey, thanks, Lori. Judd Haynes, navigator with the Port Townsend Police Department. I don't have any significant updates or news to share, so I'll happily give my time up to someone who has a lot more going on. So, oh, and I do love the acronym thing at the end of the whatever it's called, the PowerPoint presentation. Well done. Love it.
If you think of other things we should add to it, let us know.
I got tons. All right, that's it for me. Thanks.
Thank you. Chief McKern.
Recurring cool scene fire in the south end. Only exciting things we have going on is that we did, the council did approve a mental health protocol. It's fairly lengthy. The state must have loved it because the state wants to use it as a template. Once we get it narrowed down to just a few pages, it's pretty lengthy. The sheriff, thank you for looking at it and giving us some guidance there. But I think it's on the right track, and I think it's going to help us with some of those cases. As Apple said, the tables have turned on us. I can tell you in the last 3 or 4, up to 7 days, the COVID cases have quadrupled and doubled, and we're going out and seeing 2 or 3 a day. Yep, you might want to get a hold of the folks over there because we're definitely going to need some more tests. Suddenly now the tests are starting to fly again, if you will, to say. So, yep, I think the masking, and I see Dr. Barry's on here. She may have her good words of wisdom as far as, unfortunately, I think our masks are coming back, whether we like it or not. But so that's what's happening in our arena.
Well, thank you. And interesting to know that update. Chief Brummel.
Hi, Pete Brummel, East Jefferson Fire Rescue. Chief Black is off for the month, visiting his family members in Budapest. So I'm the acting fire chief until May. And yeah, there you go. Things are moving right along here. We just received some of our preliminary standards of cover and data analysis from our third-party vendor that we have reached out to for strategic plan. And things are moving along here at a rapid pace.
Great, thank you. Thank you for being here. Brian Richardson.
Hello, Brian Richardson with Dove House Recovery Cafe. We actually have some exciting news. Beginning next month, we'll be doing a meal on Wednesdays in addition to the current Thursdays and Fridays. So we're grateful for that. We've got an awesome staff member in the kitchen who's been on the job for a couple months now, who just has done a wonderful job. So grateful for her so we can make that happen. We have a full calendar for really the whole summer of pro-social sober events, and we've got more classes and club offerings for our members. They've been very engaged, so that's been fun. And then I just wanted to give a shout out to some of our partnerships. It's really feeling more recently like the Recovery Cafe is serving as a hub for networking with different resources and supports for our members. The Real Team, for example, shows up super quickly every time we call them. They've been awesome. We had the Kids at Immigration Assistance Center come today to help one of our members out. We've been having NAMI come and do presentations for us. And the YMCA up the street has been giving us Y tokens to give shower access to our members as well. So that's all been really exciting and like the fulfillment of a long held vision that was put on pause for a couple of years now. So in addition to that, we're hosting a couple of events at Recovery Cafe. Dove House is honoring Sexual Assault Awareness Month in April by holding a consent tea party Monday, April 18th, 3 to 7 p.m. here at Recovery Cafe. Masks are required for all of our events and meals. That's it.
Thank you, Brian. You know, it is exciting to see it sort of blossom right now. You guys have really just held the anchor while waiting for this pandemic to sort of lighten up enough to get your activities going and out there. Dunya.
Hi, everyone. Dunia Fo, Jefferson Healthcare. As always, we have a lot going on. I think the most pressing thing in my world is I'll be going to DC in about a week and a half to do some advocating for a number of priorities, including potentially a linear accelerator in our community. Thanks to those of you who wrote us letters of support for that earmark ask to our legislators, as well as workforce, giving them an update on COVID and how we've been responding and partnering with the folks on this call. So a lot of fun stuff. And I also have Adam and Jake on the phone who'll talk about their worlds, but a lot going on.
All right. Well, we're lucky we got you here. Adam.
Adam York, data analyst, Jefferson Healthcare. I work with Dunia. Kind of taking a step back from analytics and focused more on infrastructure. Our analytics team needs a bigger flower pot, so we're kind of expanding so that we can keep up with all the amazing requests that come our way to be able to answer things in a good fashion. So I have to stop myself because I tend to ramble when I get in.
Well, we're excited that the flower pot is going to get bigger. How about Anya?
Hello, my name is Anya Callahan, and I'm working with this group on the Harm Reduction Communications Action Plan. I know that I have time to give you my update later, so I'll let the introductions continue.
Thanks. And Jake?
Hi, everyone. Jake Davidson, Jefferson Healthcare. Well, there's lots of projects to tie into Dunia's Linear Accelerator, new building, lots of things coming down the pipeline. On our medical group side, Ann Kuman, who's our site guarantee, we actually are starting to carve out some time for her to work on a couple different things. One is called FAST program, so it's improving suicide prevention planning. So we're excited about that. And the other is looking at SMART program, which is early autism detection. So a couple cool things that we're looking to bring to the community here at Jefferson. Thanks, Lori.
So I'm going to pause introductions. We're going to come back to it in a moment. We have Dr. Berry here, and I know she has to jump off at 3:45. And she is here. I asked her to come and give us a little bit of an overview of harm reduction and to give us a chance to ask questions. And so I'm going to turn the program over to Dr. Berry right now. And thank you so much for being here. And I'm sorry I might have cut your space a little short.
No worries. Very nice to see you all. Many of you I've gotten to know over the course of the COVID-19 pandemic work. So thank you for your work on that with us. I am excited to be here to talk about something that isn't COVID primarily, just because there are so many things that we work on in public health. Just briefly, I did hear a request for tests in South County. We will make sure and fill those. And we are at the point where we do strongly recommend masking in indoor settings. We do have a case rate over 200 cases per 100,000 right now. And so the sooner we all mask indoors, the quicker that turns around. And hopefully we can prevent more significant outcomes with that kind of work. But what I'm here today to talk to you guys about is harm reduction. I know many of you are well versed in this area, but there's a wide range of comfort with the subject. So I just wanted to touch base on it a little more generally, and then speak to some of what we are considering in our programs as well, and then leave space for questions. So harm reduction is basically the idea that while we would very much prefer that people not make any risky decisions in their life, we know that people still do. And I think harm reduction has really gotten the most attention when it comes to substance use disorder, but it applies to a lot of other areas. And basically the idea that when people engage in riskier activities, we still want to mitigate the risks of those activities for them and for society as a whole, even if we would overall prefer that they don't do it. So we see that in substance use disorder, treatment and prevention services, but we also see it in things like sexual health care, making sure that people have access to safer sex options. We see it in general healthcare. I'm a primary care doctor. And so while I wish that all of my patients didn't smoke, ran 5 miles a day and ate great diets, I know most of them don't. And so I meet them where they are and kind of help them, while encouraging those healthy habits, manage the other comorbidities that come with that. And many of you overlap with healthcare, and so you know that very well. We also work on harm reduction in areas like traffic safety, where we wish everyone drove slowly and well, but we know they don't. And so we put up barriers to make sure they don't drive into oncoming traffic. And so harm reduction actually covers a wide variety of areas, but where we talk about it a lot is around substance use disorder prevention. And I think a lot of that comes from the stigma that surrounds substance use disorders, and kind of strong abstinence only messaging that we've had for quite some time. And harm reduction when it comes to substance use disorder is acknowledging that no matter what we do, some people will keep using drugs. And so how do we make sure that we protect those folks, help them live as long and meaningful a life as possible, and protect the community as a whole? So one of the harm reduction measures that we know probably the best in our community is syringe service providers. So we are one of those at Jefferson Public Health. And that's primarily came out of the HIV pandemic, looking at preventing transmission of infectious diseases in communities as a whole. And we found that in communities that brought on syringe service programs, we saw reduced rates of infectious diseases. And we also actually see reduced rates of needle litter in communities that have syringe service programs, because they have a place to turn in their syringes and an impetus to bring them, because it's generally a one-for-one exchange. And that does reduce needle litter in communities where syringe service programs happen. We also see work around Narcan. So we've been doing a lot of work on naloxone training and distribution in our region to reduce overdoses related to opiate use disorder. And I think there's been a ton of work around opiate-related harm reduction and increased access to treatment. But one of the things we commonly hear in the behavioral health realm is there are other drugs out there. What are we going to do to help reduce the damage that's done by substance use disorder related to those other drugs as well? So I pulled a little bit of our data around our overdose deaths in Jefferson County just for the last 2 years. And 25% of our overdose deaths in Jefferson County were just opiates. 25% were actually just methamphetamines. And then about 50% were combined overdoses, where people had a mixture of usually amphetamines and a narcotic. Part of why that's important is that it's important to know the whole landscape of what's going on and to make sure that we are providing services and access to reducing use of all of the drugs that are causing challenges in our region. So one of the harm reduction approaches that we are starting to consider locally, and I know you guys talked about it a bit at your last meeting, is what's called safer smoking supplies. It's kind of a newer option for syringe service providers to offer, but there is a lot of good data around it. And I just wanted to talk a little bit about why we are considering that move. So safer smoking supplies is primarily things like pipes, things like little foils for folks whose primary way that they use drugs is by smoking them. And one of the things that got me interested in this was a 2018 study out of the University of Washington looking at syringe service providers. If they provided safer smoking supplies, that up to 80% of those who were injecting actually transitioned to smoking rather than using needles. And so why would we want to do that? Primary reason is a lot of the worst possible things that come from drug use actually are all much more likely if you inject. So overdoses are more likely if you inject. The other thing that I think is particularly important for our law enforcement colleagues to be aware of is the behavioral health kind of misbehavior around amphetamine use is most common in people who inject. The high that you get from injecting amphetamines is much more likely to lead to that kind of behavioral health response, hallucinations, aggression, things like that. That's really tied to injecting amphetamines, much, much less common in folks who smoke. And so while of course we would love for no one to use meth. If we can reduce some of the crime related to meth, some of the behavioral health outcomes related to meth by helping folks transition to smoking before they're ready to get sober, I think that's worthwhile. The other thing, of course, is that it reduces rates of HIV, hepatitis C, and the other infectious diseases that we really want to prevent. The other main reason why it's starting to get traction in multiple counties around the state and in other states in the country as well is that we are seeing more and more fentanyl. And so those who are working in behavioral health and those who are working in law enforcement have very likely already come across this. We are seeing a lot more fentanyl in our community. And so transitioning from injecting to smoking does reduce the risk of overdosing due to fentanyl. But the other thing that we're seeing is people who previously engaged with syringe services are finding they can get high off of just smoking fentanyl. And so they're not, so in some cases, they're already transitioning to smoking, which is better than injecting. I'm glad they're making that transition, but we're also losing that contact with them. So most of my experience in harm reduction was in Baltimore and then in Clallam County. And in Clallam County, when I look at our syringe service programs, the way that I think of them is it's not really about the syringes. The syringes get people in the door, but it's about everything else we offer once they get there. It's referrals to treatment. It's making sure that if they have shortages of food, if they're having housing problems, we can help give them those wraparound services that make them more likely to succeed in their recovery. And so when folks transition to fentanyl and stop injecting, which again, good step in some ways, if you're going to keep using, we lose them. And so we lose that connection where we can help get them into recovery services and get them into kind of a more longstanding recovery. So that's why we're considering moving in that direction to reduce needle usage, to reduce behavioral health outcomes related to drug use, to reduce overdoses, and also to keep folks engaged and maybe get some more folks engaged who otherwise weren't engaging with us, who were just smoking meth, for example, and have not had need of our services before. We want to make sure that those who are using drugs have access to services. We think that by having them connected with us, we have our best shot at getting them to sustain sobriety. And so with that, I am happy to take any questions.
Hi, Dr. Berry, this is Kelly. Thank you for your information. I appreciate you sharing that. And it's an interesting concept for sure, as we know, right? Do we happen to know on the percentages that you had mentioned, you said 25%. Do you know if those were injected, those 25% or those 50%? Do we have a differentiation whether it was?
You know, I haven't parsed that data, but I can definitely dig into it and see if we can look at mode. A lot of times, unfortunately, a lot of this data comes from toxicology. And so we don't necessarily have the additional data around whether or not there's, needles found near them or things like that. Certainly we do in some cases related to the coroner's data, and we can dig into a little more detail. But I would say certainly, I don't want to give the impression that you can't overdose from smoking. You can, but it is much more likely with people who are injecting.
So I don't think that my office tracks the difference between injection or smoking. And so that's really interesting. And I think that with that question, I think that's something I can direct my office to start tracking.
That would be really helpful from our end for sure, if you could. Thank you.
Yeah.
As well as I wonder if we can get that anonymously from our service providers or Believe in Recovery or whomever else is engaging in that. Just might be able to give us some information on how to track those folks and support them.
Yeah, for sure. And I know we do an annual survey through the syringe service program about asking our clients what they're using, how they're using it, if they are interested in transitioning, how they're using it to a safer alternative. But I think broadening that to include some of our behavioral health service providers as well would give us kind of a better understanding of what's happening in the community as a whole. Other questions? Yeah.
Does someone else speak? Okay, hi. Thank you, Dr. Berry. That was really informative, and I just want to express my interest and support of these programs. Being a service provider and someone who's in community with folks who use drugs and folks who are trying to mitigate the harm, I think that providing pipes is a really logical next step to address our opioid overdose and meth drug use epidemic. So just really excited to hear us all talking about that, and we're already providing, hypodermic needles, and I really would love to see us provide pipes as well and be able to get more folks into healthcare settings and get more folks treatment and well.
Thank you.
Other questions for Dr. Berry?
I guess one last one is, you said you guys you're considering this or you're exploring it. What's your next step to maybe moving forward or who is going to make that decision?
So a couple things that we want to make sure. So we want to make sure that we've got all our ducks in a row as far as kind of the legal end of things, make sure that we're all doing well there. And then making sure that we have public support for it. I think when we and support among our political leaders for it, if we, and particularly Board of Health support for it, I think would be key. I think it's challenging whenever we talk about substance use disorder. It can be a very passionate topic for many, and certainly is a highly stigmatized topic. And we don't want to lead to any kind of backlash that would limit any other programs that we're doing. And so I think we are cautious as we move forward to make sure that it is acceptable to the regions where we would potentially offer these services. So we're kind of in the exploration phase there, but the final decision would really come to our Board of Health.
Is there any feedback from this group that we should consider when we go to the Board of Health asking for that? Is there agreement here that we want to go forward and ask the Board of Health for their support on this front from the members of this group, since we represent, a group that's making strides on the harm reduction front?
What specifically are we asking for?
Well, for starters, that we can use some of that funding that we have from our core for instance, safe smoking supplies. And I know that we've had votes from some of you, and I'm wanting to poll and understand how much support we have at this group before I go forward with that decision.
Well, and similarly, if anyone in this group has concerns, this is a really good time to raise them. This is a safe place to raise those concerns so that we can talk about them. It's okay if you don't like the idea. And I would love the opportunity to engage with reasons why folks might be nervous about it too.
And if anybody needs more information on how it unfolded, Ocean Mason, who is sort of the coordinator of our syringe services program, had come to me, and we discussed the possibility of having safe smoking supplies as part of our syringe services program for the very reasons that Dr. Berry has enumerated. And so then I thought, well, I'll talk to Lori about this. And so I went to Lori and talked to her about funding. And then Lori put the question up to the Behavioral Health Consortium, and many of the people on this call voted on it. And then there was some concern about what's the goal of providing safe smoking supplies to people, and some, red flags about it. And that was how it came to having a conversation with Dr. Berry, and then having Dr. Berry appear here to help us all understand what harm reduction is, and what its philosophies are, and how safe smoking supplies are related to that. And so that, I think that makes us all completely see-through. Yeah, go for it, Apple.
So I would only add to that I'm learning myself about this, and naturally have an inclination toward it because I believe in harm reduction and I want to expand what we can provide to folks in our county. And I've talked with Dr. Berry about it, and I understand that it's not something that's done very commonly across the state, though it's being considered. And so I think we're in some infancy stages here of assessment and sort of gathering our research on how this would look here. And there is natural apprehension. There are some legal portions of it to sort of drill down on. And I am taking cues with Dr. Berry as well as from our syringe exchange staff and also the public. So it's a learning opportunity, and it is good. I appreciate you saying that, Dr. Berry, that this is a safe place to just sort of bring up what the concerns are, because this is really fruitful for a gathering like this of you all to consider. So.
Example, James?
There'd be like a requirement that people like turn in their old smoking device or whatever to get a new one. I realize that may not be entirely practical, but my concern is that if the public starts seeing a lot of drug paraphernalia waste in and around our public spaces, we'll lose public support for these types of programs. And so that's a concern I have.
No, I think that's a valid concern. And I think Tacoma is one of the places that has started with this. So we could check in with them on how they're managing that. And I think definitely turning in used ones is good practice. I think one of the challenges is they're glass. And so sometimes they break. And I don't want them to pick up shards and bring them in. But if they're not broken and just used, I think that encouraging safe disposal is a consistent challenge related to these programs.
Yeah. Sorry.
Lori?
Yes, I was going to say Jim, and then Patrick, and Dr. Berry. If I interrupted you, I'm sorry.
No, I was just going to call on them.
So I just wanted to say that obviously harm reduction, many of us on this had some apprehension, but we supported it. But I think the big thing, I think Dr. Berry mentioned it, I know Anya is on top of this, is really educating the community about harm reduction and what that really looks like, because the pushback can be pretty intense. We saw what happened in SQUIM with the MAT,
yeah.
Right? And I know this is a smaller level, but it's really the same feelings and thoughts that people have when we hand out these things to individuals in the community, and they have a hard time reconcile how that's helpful. So I think it's really important that before we move forward with anything like this, that we really look at what's the community plan of action, and to really educate the community and get them ready for what we're moving forward with, because this is a small community, so we can reach out versus a Tacoma, and sell this at a different, it is a sales job in some respects. So that's all.
That's a really good point, for sure.
Patrick.
Yeah, thank you. And thank you, Dr. Berry. I have a question, but just a statement first. Stigma, of course, is a huge barrier with mental illness. And it'd be interesting to have a conversation with you and Jim about harm reduction with respect to mental illness at some point. And I know you've done that, but you may have mentioned them during the course of your remarks, but will the shift to smoking lead to, does it lead to, can it lead to folks to stop using?
I think it can be a stepping stone towards trying to reduce risk. And I think the biggest thing that helps folks move towards full recovery is engagement with people who care about them. And so the more that we can build those relationships and have easy referrals for folks that once get them that access as soon as they're ready. I think that's the goal, is to keep them engaged with services until they're ready, and then make sure they can get services quickly when they are.
Other questions or thoughts? I know Dr. Berry go ahead, Commissioner Brotherton.
Yeah, thank you, Dr. Berry, for a great breakdown of harm reduction, and I'm generally in favor of it. Patrick brought up stigma, and I think in different areas of our county, there's different stigma, and I know there's been a lot of work done as we, some people in South County, I think, feel like we're in a Mack truck headed down the harm reduction highway, but I think this is a really good path to be on. And I believe I'm the Board of Health representative on this group. And I think it would be a great conversation to take to the Board of Health too. I mean, you know, you just got to keep having the conversations and keep making safe spaces in, you know, wider and wider ripples to move this forward. So I take Jim's counsel that it's a bit of a sales job and that we need to keep talking about it and keep expanding that conversation. So I'd be happy to bring this to Board of Health.
Well, and similarly, if there are avenues, particularly in South County, for kind of smaller group discussion, I find that's very helpful. When we expanded our syringe services into Forks, it really took meeting with the business association, me and like 12 guys like talking it out. And so I think, and it's been very successful in Forks. And so if there are groups that it would be helpful for me to talk one-on-one with, I'd be happy to do that. All right, guys, I unfortunately have to leave at 3:40.
I'm just thinking about it.
Yeah, please. Okay. I've got one more minute. Go for it.
I'm just wondering how folks, okay, really quick. I'm thinking about you and I'm thinking about Mr. Brian Richardson here and how we can engage folks who are actually most likely to use these services. And if there's, I mean, it sounds like Ocean, who works at the syringe exchange program, thinks that, you know, people who use drugs would use these services. And I do think it's important to have these at, you know, big policy level conversations, but I'm also wondering how we can make sure that the folks who are going to be most impacted by this decision have a voice at the table as well.
Yeah, no, I think that's a really good point. And Ocean has started polling folks who are using our other services. And so far I've seen a lot of interest that folks would, and that sometimes the reason they inject is because they have that option and they don't have a smoking option, and that they would be more likely to switch to a safer alternative if they had safer options. I've also heard from particularly women who use drugs that having access to their own pipe would help them feel a little more free from some more abusive relationships that they're involved in, but where that's the only access that they have. So I think it could actually serve multiple benefits in this community too. So thank you for always keeping it front and center that these services need to be most tailored to the people who use them. So, thank you.
Thank you, Anya. You had mentioned my name, so I'll jump in just really briefly and say we are always open to that. We do have a captive, for lack of a better word, audience here of folks who use substances and are open to, not all of them, of course, but some would be open to, I think, having these kinds of conversations. So this is a good venue if that's something that we'd like to do. Open to.
Thank you, everyone. I really appreciate it. I'm sorry I have to jump, but thank you for welcoming me to present to your group, and I hope to see much more of you guys going forward.
Thank you, Dr. Berry. I know that there is all sorts of things that could be talked about on this. I'm sure it isn't the last conversation we'll have, but I thought it was good to start out with Dr. Berry as sort of a baseline, and then we can go from there. And we certainly welcome one-on-one conversations if anybody is interested in that as well. Any other thoughts on that topic before we move on to Anya? I do want to note that I saw something from James Kennedy here. Sorry, James, just reading it. Oh, yes. Go ahead and say what you were saying so I don't.
Just so that a lot of the deaths that we classify as suicides, it's oftentimes obvious that substances were playing a role there too. It's not uncommon that we'll come across people who, and the thing is, we have a lot of older people living by themselves, and so that's oftentimes how we come across this. But we'll have people who died of a lower GI bleed with empty bottles of alcohol or liquor all over the house. We'll have people who, and that wouldn't be considered a suicide. That would just be basically a natural causes death. But then we have other people who actually do kill themselves by, ligatures or other means, where the home will be filled with drug paraphernalia, and we'll see that obviously played a role, but it's not going to get counted down as an overdose. And so those deaths are not being factored into statistics that you see. And so just to understand, when you see overdose deaths, there's going to be still considerable more where drugs played a role, whether it's because of alcohol, which is always treated a little bit differently, although it's really not that much different, and also the suicides. So many of the suicides you see, substances are playing a role.
Thank you. I don't know how we could quantify that better when we're doing our stats or representing it as we go after grants or whatever, but I am open to ideas around that. Or even as we understand it ourselves, in our every 6-month data that we come back and sort of pour over. So something to think about there. Other thoughts on that topic? Okay, I know we didn't get to everybody in introductions. I'm thinking that let's see, Joey Rodriguez, I think we hadn't heard from you, and I know not everybody knows you.
Hi, everybody. Thanks for having me. Actually, back to Mr. Kennedy's point, we have an EMS stat that we ran in our ESO analytics in our parent account. And one of the things that we found was actually of the SI visits that we have on scene calls, 75% of them had some sort of substance use disorder associated with it. So that was very telling for us, obviously. But anyways, I just wanted to comment on that. My name is Joey. I think I met most of you at the last meeting. I'm the regional director for Olympic Ambulance. Really, my role here, I'm also representing the Northwest Region EMS and Trauma Care Council and the Washington Steering Committee. Couple of things that I'm working on right now for the executive board is trying to do a mental health and SUD needs assessment for the entire community. So I'm in the consortiums and the task forces, if you will, for the mental health and substance use groups in Mason, Kitsap, Clallam, Jefferson, Pierce, Grays Harbor, basically all of these areas. And what I'm doing is I'm going to these pockets and really asking for the right stakeholders to assist us with data. Jefferson Healthcare obviously has a big role to play in that. And what we're looking for is really, a running log or some sort of metric where we can account for boarding patients specific to mental health and substance use disorder, as well as bed availability, and kind of running those two things concurrently. One thing we need to do is really be mindful of access to care out in these rural communities. In our urban hubs that we service, it's really a different landscape. These populations a lot of times are concentrated, and we're able to kind of host large events where we go out with our ambulances and all of the stakeholders like you, subject matter experts, and really offer up those access to services and things like that. But here it's unique in nature. Port Angeles would probably be the closest to an urban area where you can kind of find a concentration of these folks. But what we're looking for is boarding patients, bed availability, and then also a length of stay versus AMA ratio. And that's a really important stat. So one thing that we've noticed, and I have plenty of data to really support this, and I'll actually try and get on the agenda next time and do a quick, share a few slides and stuff that I've been using legislatively. But one of the things that we're noticing is that when a patient is brought into the emergency room and is getting that service, before they can accept treatment or help and gain that transportation to that inpatient center, one of the things we notice is that they kind of have to sober up to accept that service. And what we're noticing is that these people AMA the minute that they start to sober up. And I don't want to generalize by any means, but that is a common theme that we see. And so what we'll see is, for example, we'll take a patient off of a 911, we'll take them to that ER, and they will not accept help. They will AMA by the time they get sober. They'll reaccess the system, and we'll kind of be in this perpetual cycle until we can finally get them to accept resources, in which then we transport them to very long distances, because there's this statewide bed shortage under Ricky's Law while everybody's trying to build their facilities and kind of get caught back up. And so one of the things that we're seeing is that these patients are then transported, let's say, to Kitsap, to a mental health facility over in Kitsap County, in which case they end up on the street again, and we encounter them again in our 911 system. And because we're kind of sporadically spread across along the regions, we're able to actually see that patient navigate through the system. And so then they end up 911 back at St. Michael in their ER. At which time then we're transporting them maybe over to Auburn or a Fairfax Everett, even up in Skagit County, only to see them back in, Port Angeles or Sequim or one of these areas in Bremerton, 5 to 14 days later. And so, just trying to work smarter and lean on, subject matter experts like all of you to kind of help us ambulance folk understand how to work a bit smarter. So that would be my ask of this group, is to kind of work with this team and try and identify some of those metrics, and really any other metrics that you guys are aware of that we should be looking at too, as it relates to kind of EMS and patient flow. The other thing that we're noticing is that we're really struggling with the distances to these beds and how long they take EMS resources out of service. We're talking 10 to 12 hours, 8 hours at a time. And like yesterday, for example, I think we turned down a Jefferson healthcare request going to Smoky Point. We had 13 patients going to Smoky Point at the same time. And you can imagine the impacts that we have, or the impact that has on our local service areas, on our, our cardiac patients, our stroke patients. Gosh forbid there's a fire department servicing, that kind of patient, because then they're browning out fire stations. And now we've got a whole other separate issue that we have to worry about. So just taking a hard look at that. One of the things that we also notice as we continue to analyze our risk at the American Ambulance Association, the Washington Ambulance Association, is that we're seeing more and more case studies and near miss reports. And we're really kind of coming to the conclusion that it's really kind of the wrong care for the wrong patient. And so it's kind of that argument of right care, wrong patient, or wrong patient, right care. And what I mean by that is that if they're a voluntary patient, what you guys might not have optics on is that if that patient changes their mind, and granted, if we're going from Forks to, to Fairfax Everett, they have a long time to think about it and change their mind. And when that patient says that they want out of the ambulance because they're voluntary, and there's that gray area between ITA and voluntary, we have no other option besides to let them out. And so we let them out of our rig. They're back on the streets. We're notifying local law enforcement, whose hands are completely tied. They don't know what to do with that information, but we feel like we have to report to someone when that patient like that. And so,
it seems like there's like maybe at our next meeting, we should have a sort of an overview of things that we could be thinking about as a group that would be supportive to you. And I'd welcome the opportunity to brainstorm that with you beforehand and jump into the next meeting and see if we can get you something solid that you can be working with from this group's perspective.
Yeah, because I mean, honestly, in the dog and pony show, going around and trying to catalyze some momentum on this. We did get budget proviso language with our lobbyists last minute. And so now Healthcare Authority is actually looking at alternative transportation methods, as well as how the hospitals will have to report that. What we're trying to do is right now we're trying to evaluate that risk versus patient experience. For example, if we know that we have all of these case studies where these people are hurting first responders or burning ambulances or running out into moving traffic, whatever the case may be, now we're kind of being forced, particularly in our urban areas, where we're restraining people 100% of the time by policy. In our rural areas, like out here on the peninsula, we're still kind of, trying to wrestle with that dynamic, because a lot of these are geriatric patients that, you just feel uncomfortable restraining. And so you kind of have this idea of, are we really doing the right thing for these patients by taking their vital signs and giving them transportation in an ambulance, and is it a proper use of healthcare dollars? So not to get winded, but we're looking at secure transport. I've got a vehicle that we've now produced, and we've got the legislative push. And so what I'm looking for is data and support from this group and law enforcement, and we were able to successfully pass the co-responder legislation. So not only trying to provide a transportation means that's safe, where these patients can be moved without restraints in the acute and crisis phase, but also in the restorative and rehabilitation phase. So for example, at the Mac Clinic in Sequim, if a patient has a dentist appointment, it's really important for these ADLs to continue and to be, supportive, to make them feel like they have, some sort of grasp and control over their normal life. And it's important to make sure they have access to that care. So how do we transport them in a humane and safe way to get them to simple doctor's appointments and things like that too? So I'll get off my soapbox, but that's kind of
Okay. Thank you. I want to quickly say thank you to everyone for being here today. It was an important conversation. I look forward to more direct conversation and seeing you all next month. I don't want you to forget, there's a slide in the package about Lisa Ray Thomas's upcoming convening that's going to be happening. Click the link, go ahead and register for that. And if there's anything you'd like to get on the agenda for the next meeting or the meeting after that, depending on how full it is, I look forward to hearing from you. Have a great afternoon.
Lori, did you want to